How are you? Can we change some background or should I go and sit there? There? Will you be able to zoom me on my face? हेलो, हेलो, हेलो रवि, हेलो।
हेलो, हाँ जी सर।
बस
गुड
ठीक है ना,
आफ्टरनून
आवाज
सर।
आ रही है मेरी?
बिल्कुल सर, बिल्कुल आ रही है। मैं एक्चुअली बाहर था इस
हाँ।
रूम के इसीलिए।
मैं एक्चुअली हम इधर हूँ, बेंगलोर में हूँ ना आज।
हाँ हाँ, वही मैंने देखा कि आप
हाँ
बाहर हैं इसका अंदर।
हाँ,
कोई
अगर
नहीं
तुम
सर।
मुझे एक को ये फोटो भेज दो तो उसको मैं बैकग्राउंड चेंज कर लेता हूँ, वही ढूंढ रहा था क्या लगाऊं।
अच्छा, तो नैम्स की लोगो भेजूँ, कैसे भेजूँ सर?
नैम्स का लोगो भेज दो, बस जेपीईजी का वही लगा दूंगा फिर, और क्या।
नैम्स का लोगो मैं भेज रहा हूँ सर आपको, अभी भेज रहा हूँ
हाँ।
सर। बिल्कुल।
अच्छा, और
श्योर
सब
श्योर।
ठीक है, बढ़िया है ना? अच्छा
हाँ,
सुनो।
बाकी सर। जी सर।
हाँ, तो दूसरा उसमें ये है कि वो जो स्लाइडें हैं बाद में दिखाएंगे, दोनों
जी।
लेक्चर जब हो जाएंगे फर्स्ट और टू, फिर दिखाएंगे कि ये हमारे लेक्चर थे। और
हाँ हाँ
और इसमें इन लोगों ने पार्टिसिपेट किया, एंड
हाँ।
पार्टिसिपेशन एनकरेजिंग था, क्योंकि यूट्यूब पे भी था, ये था वो था, जो भी है बता देंगे। और
ठीक है
उसके बाद फिर वो लोग आएंगे क्या? कुछ लोगों ने कंफर्म किया है क्या?
सर, वो दोनों लोग ऑनलाइन रहेंगे क्योंकि वो तो केरला
नहीं
बेस्ड
नहीं,
हैं।
बाकी बाकी पुराने वालों में से किसी का आया कंफर्मेशन क्या?
नहीं, कोई एक भी मेल नहीं आई सर।
तो बस ठीक है, हम बता देंगे ये लोग थे, और क्या।
हाँ, मतलब फोटो दिखा देंगे, आप बता देंगे अगर उनकी कोई कोई अगर अवेलेबल हुए, जसवंत सर उनको बात कर लो। जी।
हाँ,
तो
अगर
अगर
तुम्हारे पास कुछ है तो दिखा देना, अगर दिखाना चाहो।
मेरे पास तो सर वैसे तो कुछ नहीं, मैं देख लेता हूँ मैं कि अगर कुछ है। नहीं तो वो जो पीपीटी जो नहीं है सर, जिसमें टॉपिक्स थे और वो लेक्चर थे किस
हाँ
किस
हाँ,
दिन
बस
था।
वही दिखा देना, क्योंकि
बस
ऐसा है ना,
वो।
एक एक
जी।
घंटा वो बोलते रहेंगे, इस बीच में तुम वो कर लेना तैयार।
हाँ, ठीक है
बस।
ठीक है।
हाँ, मैं पहले
वो
बता दूंगा ये इनके लेक्चर थे, फिर आप वो पीपीटी कवर पेज वाला जो फर्स्ट पेज था वो दिखा देना, और
वो
क्या।
फर्स्ट पेज दिखा देंगे। हाँ, जो तीन तीन
बस
स्लाइडें
बस।
हैं वो एक एक करके हम दिखा देंगे इसमें।
बस ठीक है, ठीक है,
ठीक।
डन डन
ठीक है
डन, वेरी गुड, थैंक यू।
सर। ओके सर, ओके सर, वेलकम सर।
वेरी
मैं
नाइस।
आपको लोगो भेज रहा हूँ सर।
अच्छा।
ओके। हेलो। जी सर, आफ्टरनून सर। सर आज का अपडेट तो बस नेविगेट में।
Good afternoon.
How are you this one?
Sir, good afternoon, sir.
बढ़िया.
Sir, all good, sir.
मैं एक्चुअली बेंगलोर में हूँ, वहां से कर रहा हूँ.
हाँ, वही लगा सर मेरे को कि एक डिफरेंट सेटअप है काफी तो राइट राइट सर. ठीक है सर. विल स्टार्ट एट टाइम. We'll start at 3 o'clock, sir. Right.
Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day NBIM NAMS, NAMS Task Forces, AIIMS NAMS Navigate Medico CME, CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started
कैंप ऑन कर दो. हेलो डॉक्टर खरविंदर सर.
जी हाँ जी.
सर मैंने आपको मेल कर दिया है लोगो. एक ब्लैक एंड व्हाइट है, एक कलर है, अभी वही मिला है मेल पे मुझे.
कोई बात नहीं, डोंट वरी, नहीं तो ये भी ठीक है.
ठीक है सर. और जसवंत सर, आपकी साउंड बिल्कुल क्लियर है. 3 बजे से स्टार्ट करेंगे सर. और
Right.
जो नया वाला प्रोग्राम. हेलो.
हाँ, थैंक यू सर.
हेलो.
राइट राइट.
हाँ सर. और वो आपके पास मैंने आज कल रात को ना नया वाला पूरा प्रोग्राम भेजा है. इसमें लास्ट में जितने भी हमारे जो लेक्चर्स हुए हैं उनकी पूरी एक पीपीटी डिस्प्ले.
वही
तो
शेयर करेंगे आप.
हाँ, वो
ठीक
मैं
है.
शेयर करूँगा.
वो
आप
जब
जैसे
मैं
अनाउंस
लास्ट
करेंगे वो
में
मैं शेयर.
रिव्यू करूंगा ना, लास्ट में मैं
जी
बताऊंगा, तब मैं
ठीक है.
तब मैं वो करूंगा.
हाँ, जैसे सर कहेंगे वैसे हम भी कर देंगे उसके.
राइट.
ठीक है सर. श्योर. ओके. ओके सर.
started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app.
हेलो जसवंत सर, स्टार्ट कर दें?
राइट।
कर दूं सर? 3 बजे वाला है।
हाँ जी।
मैं वीडियो प्ले कर रहा हूँ।
Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint NAIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the AIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on first and third Friday of every month from 3 p.m. onwards. The NAMS-AIIMS PGIMER CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medico CME is to help them to be more proficient in their profession. Each session will covers 1 or 2 topics followed by questions and answers. Thank you for your kind support.
Hello and welcome everyone to the conclusive session of the ongoing series on oral and dental health. So this time the concluding topic is about the research, since we have all talked about uh, the various topics, various aspects in the oral health. So now now comes the most important part: how to progress further and how to do research in this field. So there are various issues regarding collaborative research and trends, what kind of research fundings which are available in India. So for this, we have two eminent speakers with us today, Dr. Denny John and Dr. Nitika Monga. So just to start with the session, I would like to request Professor O.P. Kharbanda sir for the welcome address and a brief introduction about this uh, session. So over to you, sir.
On behalf of National Academy of Medical Sciences and on behalf of the collaborating institutions, AIIMS and the PGI Chandigarh, it is my proud privilege and honor to welcome you all to this very important session on oral and dental diseases. And in the ongoing series, which we started in January, now we are concluding with the concluding lecture, where we are hoping to see all previous lecturers also, and two eminent speakers are there. The speakers have been chosen very carefully, keeping in mind the need for evidence base in oral health research. And the evidence base is required so that the patient gets the best of the treatment options and he gets the right treatment. The other aspect of research, which is very, very critical now, is that as we have huge number of dental schools, more than 315 with postgraduate disciplines, in more than 9 specialties across India. There is a need to focus on some specific areas of research which are generally need to be explored. And when we are looking at setting up a research institute or a research cell or a research department within a dental college or in a non-dental college setup, we need to know that which are the priority areas which require to be explored and from where to get the funding. So in this regard, while on evidence, Dr. Penny John will speak on collaboration as well, and the other speakers will tell us how to approach for funding, particularly with reference to ICMR. So I welcome both the eminent speakers for the day and welcome you all for the session. And I'm sure since this session is also being recorded and available online, you would further disseminate this knowledge to your colleagues and students who may be interested in oral health research. With these remarks, I will hand it over to Dr. Jaswant.
Thank you, sir. Now I request the technical team for the message from President, National Academy of Medical Sciences, the message from Dr. Digambar Behra.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you for the message. Since the current Navigate Medical CME program in coordination with AIIMS and PGIMER, so the current NAMS series on dental and oral health. It started on 2nd of January this year, and now it is concluding. So it has been very amazing journey, learning various aspects of dental sciences. So now I request Professor Kharbanda sir for his remark, because like he has been the chief coordinator of the series, and he has chosen the best topics and the best speakers in the field for those topics. So his efforts to coordinate everything has been very tremendous. So I request sir for his remark on the ongoing series and the conclusion.
With respect to this series on oral health, and dental diseases, I like to say that we chose from an introductory lecture which involved what are the main diseases, what is the global burden of disease, how global burden versus Indian burden of disease with respect to Indian population, the socioeconomic groups, the habits, and also certain diseases which are more prevalent in India than in other countries. So that emphasis was laid in the first lecture. We also introduced what are the various disciplines of dentistry. The idea was to introduce to some of our medical colleagues who are usually not aware about different specialties within dental sciences. So that was also introduced, and then we proceeded with the common diseases, and the first one was I think periodontal disease, because it has the main cause of tooth loss in Indian subcontinent, as well as it has a deep impact on the systemic health, particularly in association with heart, and also now the oral microbiome is being linked with different types of cancer in the gastrointestinal tract. So that was the other aspect. The second one after that involved, we talked about oral precancerous lesions. Then we talked about maxillofacial injuries, dental traumatic injuries and their management, prevention, the dental caries and its sequelae, particularly in children. So we had an expert from periodontic specialty who talked about to us that how the early childhood caries can be prevented, what are the needs of education to pregnant mother, and how pregnant mother can become a participant and contributor to better oral health to the newborn, who is going to be the adult eventually, and he has to take care of his oral health. We had an expert again on artificial intelligence and tele-dentistry, Dr. Deepika. She talked to us about how we can develop new devices which can help us to remotely diagnose and help in surveillance, surveying, and also the pathological aspects of in reference particularly oral cancer. And Dr. Harshpriya from AIIMS again gave us insight into the community health aspect, oral health related, oral hygiene related devices, and how these devices can be effectively used, in what age group, what device to use, how much toothpaste to use, which are the bad effects of using improper ways of brushing, and all those kind of were covered, including the fluoride in the toothpaste, its toxicity, and similar aspects. So we had another speaker from Mangaluru, Dr. Mitra, who gave us insight into what are the recent trends in the restoration and rehabilitation of the teeth, which included the newer materials, newer devices, metal-free restorations, crowns, microendodontics, dental treatment under microscope, and also aesthetic aspects of dentistry. I gave a special lecture on the problems of the maxillofacial region, where there are abnormalities in shape, size, number, cleft lip and palate, and those kind of congenital malformations. In addition, I'm just trying to rectify if I missed anything. We had um, artificial intelligence, yes, that was covered. So we covered almost every aspect of dentistry from the current perspective. What is today, what it could be tomorrow, and therefore this last lecture becomes very evident because now the research in oral health sciences is not just related to drill and fill, it is related to so many biological aspects, immunological aspects, and we need to have a collaboration with different specialties, biomedical engineering, molecular biologists, and all other fundamental scientists if we want to develop an approach to preventive dentistry and understand the etiology and pathogenesis of the oral health. So in this context, these today's lecture is very important, and without taking much time, I would request Dr. Jaswant to introduce us to the two speakers one by one, and then in the end, we will have a very small review of what has been done in the past and the concluding remarks. Thank you, sir. Thank you, Dr. Rangwan.
Thank you, sir. So now it's time to introduce the speakers of the day. Professor Danny Jones. Sir is currently sir is a senior fellow at Institute of Health Economics and Epidemiology and Translational Sciences at Kerala. He's also adjunct professor at Adelaide University, Australia, and CMC Vellore. And currently, he also serves as an expert member in advisory board of WHO and ICMR. In past, he has been associated and he has chaired the prestigious forms groups, including Campbell and Cochrane Economic Method Group. He has more than 200 academic peer-reviewed articles and book chapters. And the notable thing is that since 2022, he is listed among top 2% most cited in public health as per Elsevier and among world's top 5% scientists in the 2025 SciRank Global Registry. Sir is also on the editorial board of the reputed journals like Campbell Systematic Review and scientific reports. He is also been awarded prestigious awards, including Excellence in Clinical Research Training and Mentorship Award, Dr. APJ Abdul Kalam National Award for Oral Health Innovation and Research. I think he is the right person to guide us about the evidence-based medicine, especially in oral health. We have another eminent speaker with us, Dr. Nitika Monga. So, ma'am is currently serving as Scientist E and Program Officer of Oral Health and Gastroenterology in Indian Council of Medical Research Headquarters. Ma'am is a clinician scientist with 10 years of experience in NCD research program implementation advocacy. She initiated and coordinated national health research priority implementation project like Anand Muskan, which is the first NHRP project in oral health in the country. And she received her MDS in orthodontics and 2 years fellowship degree in cleft and craniofacial orthodontics, both from AIIMS New Delhi, and training in cleft management from Changdong Memorial Hospital at Taiwan. So, with the brief introduction of the speaker, we would like to now begin with the session without wasting much time. I would like to hand over the dais to the first speaker, Professor Danny Jones, sir, for his guidance. Over to you, sir.
Thank you. Am I audible?
Yes, sir. You are very much audible.
Okay. I'm just sharing my screen. Let me know once it's visible. Is my screen visible?
Yes, sir.
Okay. So first of all, thank you to Dr. Kharbanda for making me part of this session. I'm very pleased to be, kind of providing the concluding aspects. I'll be talking on three aspects, all the three focused on dental research. One is, of course, collaborative research. The second is what are the opportunities that are currently there in the form of opportunism, but also the current trends. I'm also highlighting what are some of the challenges and the lacunae that's happening in dentistry. So it is broadly divided into three sessions. My first session, I'll be speaking on collaborative research in dentistry. So the first time there were two gaps.
Sorry to interrupt, sir. Sorry to interrupt, sir. Please adjust your camera, sir, because your face is cutting.
Okay.
Actually, okay, sir. This is perfect. Fine. Thank you.
Thank you. Yeah, I thought okay. So way back in 2000 at the Clinical Research Roundtable at the Institute of Medicine, there were two focus areas which were identified as translational blocks. This is particularly related to dental sciences, published in one of the papers way back. I have the reference in Pitts et al. In 2011, where they identified the first gap was between the translation. I think Dr. Kharbanda already hinted at it, but the detail is that was the translation of basic science discoveries into human clinical studies. And the second one is basically the translation of new findings into clinical practice and health decision making in systems of care. And similar concerns have been raised in United Kingdom by the Cooksey report, which recognized the similar two translational gaps. And what we noticed in the red box, that there is a lot of focus now on what is called as implementation research and knowledge transfer for ensuring that the second gap is kind of fulfilled in that direction. So if I take the first gap of what is the implementation gap for translating basic science research, I noticed from my own experiences of working with basic scientists as well as AI and machine learning specialists, is that there is very poor communication between the basic and the clinical sciences, essentially mainly because these are essentially sitting in two different departments or different buildings. So they don't meet during journal clubs or any other orientation that is there, including even if you're part of a larger university. There is also no kind of systematic route for translation of research findings into clinical or public health practice. It seems that the other day I was looking at what does the time that takes for basic clinical research to end up into practice. It apparently takes around 17 years. It's reducing, but it is still very long in terms of the actual translation. And I'm sure Dr. Monga will also mention, but I found in some evidence that there is low priority by funders of research for oral health. But I think due to the recent focus of projects such as Anand Muskan, I noticed that the first funded study under the National Oral Task Force, there seems to be some renewed interest, but there still is a lot to move ahead in terms of funding for research for oral health. So that's the first implementation gap that we noticed. The second one is what is the clinical sciences and public health practice. This is not just for dentistry. I'm sure this is available. This is present even in the medical space, where you have what is called as a clinical and professionalism conservatism. Surgeons or clinicians tend to retain their interest more compared to a public health specialist, for example. And most of the economic incentives still tend to reward surgical treatment more highly than a preventive control. And there is a consistent communication failure between not only the dental subgroups, but among the research community beyond the dental subgroups as well. And that is one of the main issues, is because of the deep silos which dental health practitioners, clinicians, and researchers inhabit, as actually impacted the translation of research into policy and practice. And finally, of course, there are very limited attempts of systematic implementation of research findings for clinicians by clinicians working in health systems that promote the status quo. So these are the two gaps and some of the reasons based on my own experience and whatever little bit I could read from the theory of research that I have been doing over the last few years. So with that intention, I thought I'll just kind of highlight what is collaborative research and why is it used. So this slide is basically to show that it is a very structured partnership with individuals, academic institutions, businesses, or also government entities which work together on a shared scientific or a social objective. And the main idea, as I think Dr. Kharbanda also pointed out, is to merge these diverse expertise, skills, and resources to solve complex problems that cannot be easily tackled by a single researcher or a discipline. So in this case, you are looking at broader perspective, for example, combining different disciplines such as data science with medicine. You are looking at shared resources so that you can have access to specialized equipment, larger participant pools, and combine that single institutions may lack. One of the ways to do it would be a multi-center study and collaborate around that. And of course, final would be the real world application where both the practitioners and scientists partner together, because so that the findings are more likely to be actionable and directly benefit communities, businesses, or public policy. So this is where collaborative research is focused, and there are three levels at which this collaboration can happen. It can be either interdisciplinary, researchers from the same field, for example, two biologists working together. It could be interdisciplinary or multidisciplinary, where experts from distinct fields such as clinician and a health economist teaming up to analyze a multifaceted problem such as dental caries, for example. Or it could be institutional, global, where universities across the country or across the world, non-profits, corporate entities partner across regions or international levels to essentially scale up the impact of their research. So these are some of the background materials of collaboration. And these are the 5 types in which collaboration can happen. One is, of course, within the academic institution. Now, you could have within the dental department, or if you are working in a larger university such as MS Rama University or Amrita Institute of Medical Sciences, Kochi, then you could be collaborating within the academic institution. For example, within the faculty across 2 departments, say biotechnology and dental department. You can collaborate within the staff between 2 specific departments within the department. Administrators, in case you want to add any kind of for grants and management of this. And of course, a large pool of research can happen with the collaboration of MDS or probably the PhD students. The other type would be collaboration across academic institutions. These are very good because you can mutually share expensive and limited resources. So, for example, an IIT Delhi partnering with, let's say, Dental Institute to bring material sciences expertise on, let's say, dental materials, then that could be a mutual benefit of sharing expensive and limited resources. You can also look at collaborating with a government entity where, for example, ICMR, I'm sure Dr. Munga after my presentation will be speaking about the resources and funding opportunities that are available from the ICMR kind of an entity for research projects. There's a large availability or collaboration that can happen with private industry, especially now because of artificial intelligence and digital health being considered into dentistry, and that would be how to have innovative businesses that are kind of trying to push the influence of collaboration between academic researchers and the private sector. It is happening in a very low manner. For example, I'm also part of a team attached to Flinders University in Australia, where right at the onset of the research, where we are developing a digital health solution for multimorbidity for non-communicable diseases among the elderly, right at the inception of the research itself, it was asked to have an industry partner, and for when the solution becomes more impactful and real world. So currently we've just finished the phase 1 where we have developed the initial systematic review. We've completed the design workshop with getting the collaborators, and now we'll move into a design phase. And of course, there will be a small pilot study. And of course, and the part 2, phase 2 will be a randomized controlled trial with some cost effectiveness analysis. So the private industry in that particular research is part of both the phases, and they always bring in suggestions on what is more feasible to consider should the solution come on the ground tomorrow to get some attention from the industry. Because researchers become so engrossed in answering the research question, or they so engrossed in the methods, that do not tend to understand what is the industry looking at in parallel. And also another point that needs to be understood when we are collaborating industries, industry has to get regulatory approvals, and hence they always bring those components while the research is on. So it's been a very good experience. This has been on for almost 6 months now. We finished the initial phases and we are meeting as a team in Flinders by the end of this month, or probably first week of July, where we are bringing both the industry partners, the research funding institutions, as well as the research team. And what is beautiful in that particular intervention in this, that while the research is being done, we are also considering how regulatory aspects needs to be considered at the design stage or at the research stage itself. So that's how I have yet to see very active collaboration by the private industry as far as India is concerned, but I'm sure that there would be some activities hopefully in the near future on this objective. Of course, the last one is, of course, collaboration with international researchers. There is a very large oral health program that's already happening between UK and India. Dr. Karbanda is part of that initiative, which basically tries to bring both the value of process but also the outcomes by broadening the cultural perspectives and applications of a research project. So these are the 5 types of research collaboration that are possible. Some of us can look at. So I found this very old article called Collaboration for Improving Dentistry Model way back published in 2009. And basically it forms a triangle of focusing on one side, pursuing an informed research agenda, which you see as the blue box. Then, of course, effective dissemination of research findings. And of course, last one being effective implementation of research findings. And it essentially tries to say that primary research built on critical appraisal, built on systematic reviews, goes into dissemination of findings. You need to engage stakeholders, groups alongside education providers. And of course, the whole collaboration has to be alongside patients and clinicians. And I think this is a very nice model. But I thought, what can we do for a model for India? I believe the CEID model for India should look at interdisciplinary. It has to look at a multi-institutional. We should look at international collaboration, not only because one of the reasons that very large studies are possible in India is because we have a very large population. But for me, when I talk to my collaborators, one of the questions that I always ask is, why are you interested in the collaboration? And the essential reason that they give is, even in a small population, in a small geography, the diversity in population, which is very important in epidemiology because we call it heterogeneity, that gives a very real world essence into any research in India. So I think that is something that we need to explore more, but also exploit to some extent. And of course, what is finally not happening is a very deep-rooted public-private partnership. And when I'm saying public, it is not just about the institutional funding such as ICMR, DHR or DST or the newly formed Anusandhan National Research Foundation, but I'm also talking about patients and patient groups being part, because what they bring to the table in terms of problems or the questions that might deserve to develop a research question, I believe is something that is lacking. I'm at CMC Vellore, we are trying to set up a patient advocacy, not set up a patient advocacy group, but we're trying to figure out how do we engage patient advocacy groups to be part of research projects at the CMC. And we are figuring out how do we translate all these high-level research projects into for their better engagement, but also active participation. So I think that is what I would believe would be a very strategic way of looking at CID model for India. So, however, I should also say that there are some barriers, and the main barrier being funding deficiency. I'm sure Dr. Monga would probably throw more light on that. There's a huge geographical imbalance, mainly because of many funding and other institutions being in the north. For example, and some of my research project currently is focused on northeast of India. I have some 5 states where I do research. One Assam, Meghalaya, Arunachal, Tripura, Manipur, and of course Mizoram. Nagaland is not there at this particular moment, and Sikkim, of course. So there's a lot of geographical imbalance in those areas, especially where research and implementation become very challenging. Funding is also required at a greater level, mainly because the travel cost is very high in some of those areas. So there is this geographical imbalance, mainly also because of trained personnel who are available to conduct proper data collection and also for all other research purposes. Then, of course, the third one being institutional silos, department-wise, within the department, across two faculties, let's say dental as well as engineering. There's also a huge digital infrastructure gaps. A lot of the dentistry documents, all of those medical records are still in the manual form. It has to be yet to be digitalized. Of course, as I mentioned, there's a very huge trained researcher shortage, and there are these data privacy concerns because it involves data of one institution to be passed on to the other institution. And because a sizable number of the dental institutions in India is private, they also feel very concerned about how to share this data across two different institutions. So I believe these are what my observations of working with dental research for the last few years have been in terms of 6 barriers for collaboration in dental health research. I'm sure in the end we can probably have some discussion and thoughts. Even I would like to hear from others about some of these opinions or suggestions that I'm making here. Part 2, I'm going to talk about research opportunism, but I thought I'll first start with the publish or perish in what is required as an Indian, in what is happening in the Indian dentistry academic areas, mainly because of mandates. I saw this website called the Thesis Right Cafe, which actually provides everything related to dental research, right from choosing the research question. I just put part of the entire website, but it helps you to write. All you have to do is frame the research question. They'll do everything, and all you have to do is just do the data collection. Because of these kind of activities, but also the focus on publish and perish, mandates that require publications for faculty appointments, promotions, requires a very intense publication pressure. And because of that, there is a generation of fertile market for opportunistic research practices. There's also this kind of a recent movement in universities and institutions for providing cash incentive for publication, which incentivize quantity over quality. So it's more about whether it is Scopus index, but not about whether what is the kind of impact that the journal has or the article has. So there is this a very incentive over quantity over quality, for example. And finally, of course, there are these infrastructure gaps, not in terms of very insufficient research training, mentorship for research, ethics education. I'll be talking a bit more on research integrity office, which is completely missing in almost all of the dental schools in the country. The second point is, of course, which is there, but also kind of hidden, but focusing more on predatory publication in publishing in India. So the scale of the problem is very huge. India hosts the world's largest share of predatory journals. Indian authors alone made around 34% of their all articles in predatory journals. And plagiarism is almost high in non-self-reported dental studies at 27.9 and 21.7% at data fabrication. And there's a very large maximum number, and this is from a very international journal, which mentioned that the maximum retractions of dentistry-related research originated from India, almost 24.3%, and on average took 2.6 years to be issued a retraction notice. So it takes a very long time for the retractions to be identified, and the retractions kind of dilute, because by then in 2 years, lot of other papers or other publications would be citing that research, which leads to a kind of a circle of predatory publication feeding into more kind of dubious research. I found this good guide, but this was published in biomedical engineering, and they have a journal, they have a practical guide for researchers on how to identify predatory journals. And it is very difficult. I've done some work when I was very attached to Cochrane at one particular time. I'm not that attached anymore these days because of I moved away to other positions. Where we try to check how can you identify whether a journal is actually predatory. Let me tell you, it is not very easy because you have to actually work like a detective. It doesn't feel like the journals these days are very good to replicate the journal interface. It looks very professional. There are various tools like Think do checked act tool, but I think what would be required probably as a reference would be a very practical guide, which is very usable, not just listing down scopus. One of the things that we published a paper way back in 2000, probably around 2016. It was presented as a poster at the Cochrane Colloquium in Edinburgh, where we try to check what are the types of predatory journals that are published in systematic reviews from India. And we found it is not very easy, because we found journals which are indexed in Scopus but still looks like it seems to be predatory, which means that there is a higher chance that the journal could be predatory. And this could be basically because, for very reasons, it might not have a publication fee problem. That is not the issue, but there were many instances where an article gets submitted, let's say by 10th of June, and less than a month, the article gets published or accepted, and then of course it gets published because there's a publication fee. Now, having been part of the reviewer group, reviewers kind of circle over the last decade or so, and being an associate editor, let me tell you that even to select the right reviewer takes around 2 weeks, leave alone a good reviewer coming back and giving comments. So traditionally, it should take around 2 months minimum for an article to be gone to the right set of two reviewers to provide deeper, proper comments and improve science. I don't think we follow that principle very clearly, but probably one of the ways would be a very practical guide for dental researchers on how can they identify predatory journals. This was an article published in 2020, which was a commentary actually which was basically highlighting that, which was something that even I was saying, that it is necessary to these two authors were suggesting that the journals which are indexed in the UGC care, do not actually distinguish between predatory and legitimate journals. So you will find that there are journals listed in the UGC care, indexed in Scopus, but they could be predatory in its form. And that is why such a blanket approval would provide some ample scope. And hence, the author suggests that they need to revise the DCI guidelines. And essentially, now that we also have, today only I was looking at, now do we have one nation, one publication policy, where there are recognized institutions will get their publication fee covered by the government of India. I think they have listed some kind of criteria. So it becomes even more important that we choose the journals that get eligible under this subscription model, because it is talking about public money in the end of the day. So these are some of the challenges that I've noticed as far as research is concerned. And the other, of course, which is very well known, ghost authorship. I don't want to highlight too much. Gift authorship, and of course, guest and honorary authorship. There is this ICMG criteria, which tells very clearly that it has to be met. All the 4 criteria has to be met in terms of conception, design, drafting, critical review, and of course, accountability. So having said that, I thought last I'll be focusing, as Dr. Kharbanda also highlighted, is what are the current trends in dental research? What could be the ways in which some of the participants and researchers can think about? So I've divided the entire areas into a few sections. The first section I thought would be, what is the whole systematic review, because evidence synthesis or systematic reviews are being proposed as a factor for post-graduation as well as PhD research. This was a paper published in 2022, which looked at there is a very rise in the number of systematic reviews that are published in dental research, but the findings actually do conclude that it could be poor state in India, both in terms of quantity and quality. The numbers are quite high. Today morning, while I was preparing the presentation, I just put dentistry India systematic reviews, and I got so many systematic reviews already published. So you notice that it's a huge rise from 2010. You will notice that before 2007, there was not a single systematic review published in India. And from 2010 to 26, you see a very large number. In fact, for this year, if you notice, just in PubMed, there are almost 242 systematic reviews that are published in PubMed from India. So I did dentistry, I put India, and I put systematic reviews as a filter, and I got these numbers, and I prepared the graph accordingly. The main challenge is systematic reviews fall back on primary research. There are challenges on the reporting of RCTs in dental journals being poor, mainly because of the consort-based evaluation published. Now, this paper tried to look at 10 Indian public academic dental journals, 2011. They did between 2011 and 12, found that the mean reporting score as per the consort guidelines are only 12.2 compared to 25, with almost 69% failing to justify any sample size, 89% lacking any allocation concealment details, and 86% not reporting any funding sources. So the main challenge for evidence synthesis is not the number of systematic reviews or the type of systematic reviews or any good systematic reviews, because it also depend on the primary studies. If the primary studies are methodologically poor, then it is going to affect the kind of systematic reviews that will generate, because all the systematic reviews was going to give us is either moderate or very poor quality of evidence, mainly because there are these methodological qualities. AMSTAR-based checklist, I found that the most common flaw being methodological quality issues around selection and data extraction. Almost globally also, it's not just an India problem, but globally problem that almost less than 1% were classified as high methodological quality. This in Cochrane, Ian Chalmers mentioned it as research waste. Imagine 100 studies and less than 1% is talking about it, because in India we do not count time, effort into cost. If I actually capture cost of doing research or to do a systematic review, I'm sure we are talking about GDP loss of millions of dollars here. So I think we need to understand that efforts that we do in research, if it's less than 1% is going to be of a high quality, then we have a global problem. Also, there are these issues not only for systematic reviews, but essentially the way systematic review abstracts have been mentioned in general dental journals. And of course, only search, which is the primary foundation of any systematic review, less than 59% actually recorded very clearly in this systematic review. So one of the issues is not just the rise in the numbers, but I think we have to focus on the quality of research and the quality of systematic reviews that are coming out. I think quality over quantity would be the main criteria in which we need to look at. The second, of course, is artificial intelligence in dentistry. It seems to be very positive in some areas. If I notice, this is something that I developed early in the morning for this presentation, where you look at the blue bars represent single country publications and orange bars represent multi-country collaborations. India currently ranks third globally with 19 articles, of which 15 were single country and 4 multi-country. So essentially in dentistry, as far as AI and dentistry publications are concerned, India seems to be doing pretty well. Of course, the gap between China and India is very huge, but at least we are better than Germany and USA for that matter. So I think we need to feel a little proud on that numbers.
Hello.
But there are these lot of newer digital dentistry areas that's going to become very important. Intraoral scanners, which are going to replace conventional impressions, reducing remakes, multi-chair clinical option accelerating, 3D printing, which are becoming less cheaper day by day. And of course, teledentistry, which can focus on virtual consultations for rural underserved, remote orthodontic monitoring as well. So research imperatives are, last year, 2025, the Global Conclave on Oral Health and Research focused on saying that outcome evaluation frameworks for new technologies are lacking in the country. Digital literacy gaps very high, especially among the practitioners which are based in tier 2 and tier 3 cities. And we all are aware that there is no unified national oral health information system yet, which unifies all of the oral health institutions together, so that real world evidence is available not only within the hospital, but across the states and districts as well. So I work very closely with public health dentistry departments, at least at 2 institutions in Ramaya as well as in Amrita in Kochi. And I feel that, so I was trying to look at what are the trends which are focused on public health dentistry. And I think this is something that could be very important. So we all are aware core project, which is where Dr. Kharbanda is a member there. It's called looks at equity mapping. There's a teledentistry. There is AI in oral screening. Recently, ISC and Biocon Foundation, there's also an app that is developed. NCDs and clinical risk integration. Commercial determinants focus is rising, especially around policies such as sugar and tobacco industry modeling, but also its relationships to oral health surveillance in terms of ABDM integration, and of course, finally, the universal health coverage integration, which looks at national average. So there seems to be a lot of high focus in all of these areas. It's also rising, especially around commercial determinant. There's a nice group which in Bangalore focusing on the influence of tobacco and sorry, not just in Bangalore, but also in Chandigarh as well, focusing on how the tobacco industry focuses on and its association and its influence on tobacco use, and how does it get associated with oral cancer incidence and prevalence, and of course the whole influence of sugar and the incentives around sugar for some of the commercial, which now is called the commercial determinants of health as a focus. But I was looking at what are the emerging areas in Indian dentistry. Of course, the first one would be the whole genomics, precision dentistry, such as periodontitis, genetic risk profiling, microbiome studies, biomaterials innovation. I think there's a huge gap on biomaterials innovation, and of course, oral systemic links, oral cancer research, and finally, health economics of oral health, specifically around cost effectiveness of preventive interventions, catastrophic health expenditure, and of course, dental insurance policy analysis. So these are some of the research areas that are emerging. I'm happy to listen to the participants at the end of this session to learn about how could some of these areas are. Did I miss on anything, something that is important? But I thought just to bring everything closer together, these are, I thought that as a category, this could be the priority research areas given the quality of research that is coming, and research being part of BDS, MDS, and PhD curriculum, to look at university-based student startups, student projects as well. You could look at new basic dental materials, university-based patents, funds, grants, adoption and implementation of new technology, and of course, basic sciences research, in vitro research, especially around focused on oral health. I thought I'll just present the last few slides focusing on research integrity, because somehow this has not been that provided that much important, although institutions such as ICMR and Rajiv Gandhi Center for Biotechnology have launched an Office of Scientific Integrity. So the Indian government has initiated, or the UGC has focused on a CARE, Consortium for Academic Research and Ethics, to promote research integrity in India. Only two institutions till date, which are basically academic institutions. One is, of course, the NCBS, and the other one being Center for Brain Research in Bangalore. They came together and partnered to create India's first dedicated research ethics and integrated office. ICMR has designated research integrity office across their network of institutions, and Rajiv Gandhi Center for Biotechnology has launched an Office of Scientific Integrity. All other institutions, Indian universities have institutes, including IITs, have no kind of unit on research integrity. Now, why do I feel or say that it matters? Is because UGC suggests issues are only a recommendation. There are no basic mandate or funding attached to it. However, Anusandhan National Research Foundation has recently unveiled a rule that they have to, all the grant applicants have to mandatory declare their details and reasons for any publication retraction in the last 5 years. One of the things that is important. I thought I'll highlight a news which got published in 2022, where a retired scientist from ICMR was actually who co-authored and had flagged image manipulation. Now, because he's retired, there is no way to make any action. But that is the challenge why institutions need to have a research integrity office, because it not only affects your present, but also whatever research has been done in the past. The second, of course, papers in predatory journals rarely get retracted. So it actually masks the true scale of misconduct. Most of the retractions are happening these days, and there's a website called PubPeer, PUBPEER, which identify where there are these research sleuths. These are detectives who go to each article which was published and tries to check was there any integrity issues in that particular journal. But the majority of retractions are happening due to challenges around images. And image twin or any other such image screening tools are very costly to adopt. And hence, trying, and of course, one of the challenges in India or in the unlike the US or recently, for example, in Norway or in Canada, there was a PhD student whose granted PhD was retracted back because a PhD was found to have issues around research integrity once the papers got published and the papers got retracted. But that was the first case where a PhD degree was revoked due to issues of retraction later after publication. Because all institutions bother is the publication but doesn't follow through on which journal was it an issue of retraction in the future. We don't have softwares or mechanisms to do it. So hence the research integrity office matters a lot. Also because image screening tools such as image twin will be very too costly to adopt. So that's the few cents that I had to share. Thank you all for your patient listening. Happy to answer any questions or comments either now or later. Thank you.
Thank you, sir, for the informative session. And definitely this will help the researchers in the field. So now I request ma'am, Nitika Monga ma'am, her topic is regarding research funding opportunities in oral health in India. So she is going to present the ICMR perspective. So ma'am, over to you for the
Yeah. So,
next
thank you,
session.
Jaswant, for handing me. I hope I'm audible.
Yeah, ma'am, you are audible.
Just
Ma'am.
confirm. Yeah, thank you
Yes, ma'am.
for setting. Thank you to first NAMS and especially Dr. Kharmanda, who has been working, I think, last 6 months over this. And it is a very well thought initiative and well planned initiative, I must say that, and much need of the hour because oral health research is something which is, really important and coming up. And I probably next 10 years, I see a lot of work happening in this area, in the area of oral health research, which was probably neglected earlier. And also thank you to Dr. Denny John for setting up the stage. I think he's beautifully, touched upon very important points in the area of oral health research, and I resonate with him on most of the points. Further discussions can continue for both of our presentations. So I'll now begin with my presentation for today. I'm supposed to speak about the various research opportunities in oral health in India. So, I don't know, I'm not able to. Yeah. So you must be aware of the various steps in research proposal. We always begin with first designing a project and then we recognize whether funding is really required for that type of project or not. And if the answer to that question is yes, then we need to identify the potential funding agencies or sources for the same. And then we assess the cost by category and construct a financial plan. And finally, we write a full research funding proposal and submit to the agency. So the various funding sources, potential funding sources are being listed here in the slide. You can take a picture of it. So I'll be talking about the funding sources from Indian Council of Medical Research, where I work. So, for those who do not know, that Indian Council of Medical Research has been established in 1911 and is an apex body in India for the formulation, coordination, promotion of biomedical research and is one of the oldest medical research bodies in the world. So I've tried to categorize the research opportunities as per the level of career of, right from the undergraduate level till a regular employee and even emeritus scientist level. So I've tried to categorize the research opportunities according to the career level. So we'll be talking about the undergraduate research opportunities first. So for the undergraduates, ICMR had initiated an STS student short-term studentship program in 1979. And now it is for BDS or MBBS students who are currently in first year and second year of their course. So that, it is an incentive to them to take research as a career. And every year, nearly 2,000 proposals are being awarded, which is roughly about 2% of the total medical or dental UG seats. And amongst them, 80% is given to the MBBS students and 20% to the BDS students. And the person who qualifies for that or gets selected, he receives a stipend of rupees 60,000 for 6 months of research work, which they're supposed to do over a period of next 3 years. For example, a first year student he has to continue it till third year, and second year student has to continue it till fourth year of BDS or MBBS. And 2 months of their summer vacation each year, they're supposed to do this work. The next opportunity that I'm going to touch upon is for the postgraduate students for their thesis support program. So it is to support medical and dental college students for pursuing thesis research work during post-graduation, which probably I was lucky enough to even, get this thesis support during my post-graduation. So nearly 400 per year are awarded under this category, which is roughly 1% of total medical PGs in India. And it comes in 2 batches, one batch in June, another next in December, because in many places of national institutes, the PGs get recruited in 2 batches of June and December. So accordingly, this has been prepared in 2 batches. And 80% of the medical PGs are awarded and 20% dental PGs are awarded under this program. And they get a grant of 1 lakh release in 2 installments. Initially 50,000 at the time of once they submit the protocol and once they're selected with an undertaking. And the second installment is once they publish their thesis work within 2 years of their thesis submission. The next opportunity is for the students who want to pursue PhD after their graduation or post-graduation. For them, there is a medical PhD program, which is of 2 categories. One is medical PhD program for graduates and postgraduates. And the second one is for the young medical faculty who are faculty in any of the medical or dental colleges. So for the BDS or MBBS or BDS students, if they're not drawing salary from any other source, so they get a remuneration of 3,000 per month up to 5 years or PhD, whichever is earlier. And similarly, an MD or MDS is supposed they get a remuneration of 96,000 per month up to 2 years of PhD, whichever is earlier. And apart from that, they receive a research grant for 10 lakh per year for up to 5 years or until PhD completion. The second category is for the young medical faculty or PhD program for regular medical faculty with 1 year of service at an NMC or DCI recognized medical college. And since they're already drawing salary because they're regular employees, so they're just given research grant of up to 50 lakhs for 5 years or completion of PhD. The next opportunity that I'm going to now touch upon is for the regular employees. So for the regular employees, they have an opportunity of short-term fellowship abroad, and the second one is for long-term fellowship abroad. For the short-term fellowship, it is for a period of 15 days to 3 months, and it is eligible for MD or MDS, that's postgraduate or graduate plus PhD people with at least 3 years of experience below the age of 57 years, and they get a stipend of around $3,000 per month. And for the long-term fellowship abroad, that is for a period of 6 to 12 months, the eligibility is again postgraduate or graduate with PhD with at least 3 years of experience, an age limit of below 45 years, and stipend of US dollars 3,000 per month, which includes accommodation and expenses. So next opportunity that this opportunity even postgraduates can apply for is the International Travel Grant Support for non-DHR ICER scientists and researchers. This is for everybody, which the purpose is that financial support for biomedical researchers, PG students to attend and present at international conference, seminar and symposia, but they must submit at least 2 months before the event. That is the minimum duration that prior they have to submit the application, and it is based on the scientific review by a committee constituted by Secretary DHR, that's Department of Health Research. And up to 1.5 lakhs is the maximum grant that is given under this scheme for international travel grant. It is not moving it. The next category is for the workshop funding grant in biomedical research. The target group is government and private institutions conducting workshops on research methodology, ethics, and research capacity building. And the selection process is a scientific review of workshop proposals by a selection committee. And the financial support is rupees 10 lakhs per workshop. And these are the 12 areas where currently, you can take a picture of it if you want to. Currently, workshop grant is being provided, but earlier it used to be for conference grant as well, but now currently it is only for hands-on workshop courses that this grant is being provided. So all the schemes that I mentioned till now, they are being tackled by Department of Health Research, by HRD, Human Resource Development Division, and the scheme generally comes in the month of March or April. Most of the schemes come during that duration. However, you can keep on frequently visiting that site for any further information or schemes that keep on coming. So I will now be coming to the 4 types of basic research that happens at ICMR. So that is called 4Ds. It comes under that funding comes under 4Ds. That is descriptive, discovery, development, and delivery research. So I'll be just apprising you about the 4 types of research. The discovery research is aimed at finding novel interventions. That's a basic type of research. It's a preclinical or phase 1 studies come under it. This type of research. The second type of research is development research, which is aimed at developing or validation of interventions for screening, diagnosis, prevention, treatment of disease condition, or make the existing interventions simpler, safer, more efficacious, or affordable. I'm trying to apprise you about the 4D because when you submit your proposal, you'll have to select the category amongst the 4Ds under which you want to submit the proposal. Then the third type is delivery research or implementation research. Dr. Danny John had been talking about it in the previous session, which is aimed at learning how to overcome barriers in delivering effective interventions to the people who need them. And this will include health system-based interventions to increase access and to successfully implement the National Health Program or schemes, reducing the inequity and improve the quality of healthcare. The fourth category is the descriptive research, which is basically aimed at finding the pathogenesis or etiology or describing a condition or disease, which might be a prevalence, burden, risk factor, or determinants of the disease. So that type of research is called descriptive research. So currently the impetus of funding for research project at ICMR is on development and delivery of implementation research. For descriptive and discovery research, it will be done in the areas where it doesn't exist. But current impetus is on development and delivery research. So if you submit a proposal in these 2 areas, your chances of getting funding will be higher. So now I'll come to the types of external research grants that ICMR provides. So the first category, I'll be talking for them by one by one for these projects. The first category is a small grant investigator initiated research proposals. Then we have intermediate grant investigator initiated research proposals. Investigator initiated first in world challenge is the new scheme that has been started. These are the high risk, high reward type of projects that have started. And the next category is the investigator initiated Center for Advanced Research and Excellence projects. There's a new scheme that has recently come up that is a clinical care excellence initiative, multi-center clinical trial addressing the non-communicable diseases. And then the last one, which is the highest ethics type of research projects, that's the National Health Research Priority projects. And apart from them, ICMR is also, trying. The proposal has been submitted to Ministry for initiating 1,000 clinical trials, which are academic and industry-sponsored clinical trial units that are coming soon, probably in the country. That is a new scheme that's coming up. Apart from that. So coming to the small grant investigator initiated project, they are to promote research in the country in the field of biomedical research. And the financial support is provided to medical college, research institute, university, recognized research, R&D laboratory, government, semi-government, private NGOs, all categories are included in this category. And financial scaling is up to 2 crores for a period of 3 years. The next category is the intermediate grant investigator initiated projects, which are multicentric, preferably multicentric, but they can be unicentric as well if they are done in one district, which encompasses, a very big sample size or their implementation type of projects. And in such cases, it can be unicentric as well, but it is generally a multicentric category, time bound with a goal-oriented approach and clearly defined targets with specific time frames. It has standardized and uniform methodologies, and the duration is 4 years maximum, and the budget is about 2 to 8 CRs. The next category is the First in World Challenge, which is a new scheme based upon Chandrayaan 3. And based upon that, the scheme has been initiated, and this is for high reward, high risk and high reward type of category to initiate, which is, as the name says, first in the world, and those type of projects to support groundbreaking biomedical innovations that have never been thought, tested, or tried in the world. So it is for scientists, faculty working in government medical colleges, Indian institutes of INIs and ISO institutes, universities, recognized R&D laboratories, NGOs, private institutions, and Indian startups and industries are also eligible for this category. And it comes under three, initially three level, that is proof of concept, which is up to 1 crore, up to 2 crores. And the next one, once a person, delivers in the proof of concept, he'll be then moved to the next category, that is prototype development, which is up to 4 crores, up to three years. And then he'll move to the next category if he delivers in the second category to final product or model development, which will again be of 8 crores up to 4 years. So he will be moved from TRL 1 till TRL 3 or 4 under this category. So the next category is the Clinical Care Excellence Initiative or a multi-center clinical trial addressing non-communicable diseases. This is again a new scheme that has come up for clinical trials, non-regulatory clinical trials, that is academic clinical trials in the area of NCD. And then each center should have minimum 5 participating clinical institutes for participant enrollment. And there can be one PI lead site, and then there can be multiple OPIs from each participating sites. And again, the financial ceiling is 8 crores per project for up to 4 years. So currently the process for selection of these projects is currently ongoing for these projects. The next category is the Investigator-Initiated Center for Advanced Research and Excellence category, which is to encourage in-depth research of a disease or health condition, and they focus on aspects like causation, progression, management, and prevention. And it is created around scientists of eminence, which is undertaking excellent work in that concerned area. And financial ceiling for such type of projects is 15 crores for up to 5 years. So all these schemes till now were investigator-initiated programs, and the calls they keep on coming on the website, and you can apply accordingly. And they go through a selection process, which is a very critical selection process, and it probably goes to 2 or 3 tiers of screening that the projects come, because for small grants probably we have nearly at least 7,000 to 8,000 projects that come in each call, and similarly for intermediate grants, roughly 3,000 to 4,000 come under that category. And out of those, nearly 900 or 2,000 small grant projects are selected. So you can say from almost 8,000, 1,000 projects are selected each year in the small grant category. That's a proportion. So that's a competitive level of the projects that are being selected. So I'll be moving now to the next category, that's the National Health Research Priority Projects, which is the highest apex level of projects, and they are probably centrally coordinated projects. And they're large, decisive, multi-state projects with a strong emphasis on addressing program needs. There are 11 specified disease conditions identified for National Health Research Priority Projects, and funding of up to 25 crores for each project is granted. And the beauty of these projects is that ICMR floats an expression of interest. You have to just, provide your expression of interest in the form of small concept note. And then these projects are co-developed with the participant of applicant and ICMR. So the PI individually doesn't need to develop that project. The project is being co-developed with ICMR and then ICMR experts for this category. They are mostly multi-centric with commonly agreed upon protocol, and the focus is to bring about significant and impactful improvement in the priority health challenges. So in June 2023, ICMI Ministry of Health Family Welfare approved the NHRP in the following areas, and amongst those 11 areas, oral health, I'm happy to say that oral health is one of those areas. So it is now finally probably getting the heat it deserves. So before I come to the detail of that priority project that we have undertaken, I'd just like to, apprise about the global burden in oral health. I'm sure your first lectures of the series was on this, but I'll be briefly going through it. So most of you would already be knowing that it is the most widespread preventable disease, higher than any other NCD, and it has remained unchanged at 45% for the past 3 decades, affecting about 3.5 billion people globally. And if you see the circle, you can make out that oral disease is the biggest circle. All the NCDs put together, those circles, oral health prevalence is probably the highest. If I come at the GBD data of 2017, you can see, amongst the prevalence for 286 NCD diseases, oral disorders is at the top with the highest prevalence, and it has remained unchanged for the past 3 decades. And again, if I touch upon the GBD 2019 data of country-wise cumulative prevalence of top 5 leading cause of oral disease, so India tops in 4 out of 5 in prevalence of oral disease. In only one condition, it is second after China. But out of the 5 diseases, that is caries of permanent teeth, severe periodontal disease, caries of deciduous teeth, and then lip and oral cavity cancer, India tops amongst those, with only edentullism, India being second after China. So this is where we stand. And we have nearly 66.7 crore, almost 50% citizens of India suffering from this condition. So the WHO Oral Health Research Agenda has, they have a target that by 2030 we need to 50% of the countries they need to have national oral health research agenda, which is focused on public health and population-based interventions. And we need to prioritize oral health research of public health interest, strengthen the implementation and operational research, close gaps in evidence and translation of research into practice for upstream interventions. Upstream interventions are the interventions which are at promotion and prevention, and downstream are the ones in which we focus more on management part. So we need to focus more on the upstream interventions, and oral health promotion in key settings such as schools is what they suggest we should take up. So why do we need implementation research? I think Dr. Jenny Denijohn already mentioned in this slide that it takes approximately 17 years for only 14% of our medical research evidence to reach clinical practice. And nearly 85% of our medical research evidence never enters the clinical practice. And fewer than 50% of clinical inventions are ever integrated into clinical practice. So there is a huge gap between our research and translation of the research. So what we can see. So that is why we need implementation research to deliver, the evidence-based interventions to the people who actually need it. So this is what implementation research does. So the journey of National Health Research Priority Implementation Research in Oral Health Anand Muskan began at ICMR. And it is, the first national implementation research project in oral health, about 25 crore. So why we call it Anand Muskan? Because Anant means, endless smiles. The smile which never ends, and it can only happen by prevention and promotion. It can never happen by management alone. So with this thought, we named it Anand Muskan and we began Anand Muskan. So as has already been mentioned, we have nearly 50% of the people in our country who have dental caries, and the stats are similar for India, so which reflects a high burden of dental caries amongst the Indian population. So definitely there was a burden which was observed. And then we had 12 global school, we had 12 different toothbrushing programs, global school toothbrushing programs in various countries. 25 programs in 12 countries. School toothbrushing programs are already in place. 7 guidelines had already come up. And the key finding that they showed us was that delivery of toothbrushing programs in schools and other early childhood settings has the ability to address social determinants that impact oral health through a settings approach. So this is how the journey of Anand Muskan began, which is the first implementation research or school toothbrushing program in our country. And we began with a brainstorming meeting. We first identified, the key areas to prioritization exercise, followed by selection of priority research area, then release of expression of interest. Then post that 96 proposals had been received in response to that expression of interest. And that was reviewed by 5 experts, which were interdisciplinary experts, which included oral health experts, interdisciplinary oral health experts, and we had implementation research, we had biostatistician in place, and we had pediatricians there in our committee. So it was an interdisciplinary group of experts that actually looked into the projects, and they scored the projects in a quantitative way. And then the top 8 sites were chosen from 6 zones. Though from North India, we had 3 sites which came in top 8, but we could not take all of them because we had to keep a balance between the zone. And so from North India, we could have only 2 sites, and there were more sites of North India into top 8, but we could only take 2 sites in North India, and not all of them. And then for the next 6 months, there was a rigorous exercise, developing the protocol. Dr. Karmanda was part of it. He knows very well. Dr. Denijohn is also, one of the co-investigators at one of the sites. He is also fully aware, I think, of the process. Then over a period of six months, there was a rigorous exercise of developing the protocol together. All sat together, all the experts, representatives from Ministry of Health, Ministry of Education, NOHP, School Health Program, and primary school teachers, representatives. Obviously, the 8 participating selected sites, they all sat together and they co-developed the protocol. So the aim was to develop and implement a school-based oral health delivery model with high coverage amongst primary school children to improve the oral health. The core intervention package was school-based daily toothbrushing because we already had an evidence-based, this was an evidence-based intervention in place. We knew that fluoride-based toothbrushing, it reduces dental caries. So we already had that intervention in place. And oral health education, both the intervention are the core, though there are many strategies built around it, but this is the core intervention package that we are delivering under this program. So the study population is children in primary school because these children, behavior modification is easier in these children. Once these young children are taught the correct way of toothbrushing, it can actually serve them a lifetime and prevent many oral diseases in the cavity. So all types of schools, because there's an implementation research, and tomorrow if we have to implement it country-wise, we cannot ignore any strata of the school. So all types of schools like urban, rural, government, private, all categories of schools were taken. And 8 sites were chosen, study sites. And then we had the various phases, right from preparatory phase, then formative phase, pilot phase, implementation phase, and consolidation, dissemination, exit phase. So this was the whole plan that was made for all the phases of this program or project. And then you can see in this chart, this was the baseline analysis of the caries prevalence that was done under this project. And you can see the various caries prevalence, with Lucknow being the highest at 92.6%. So though initial data literature review said that 50% is the caries prevalence, but what is coming out is quite high prevalence in our project because Lucknow is 92.6%, and the maximum sites around 63 or 73%. Lucknow is the highest and Delhi is the lowest, the 6.65%. So that's the range that's coming and caries prevalence in the country. So the various outcome parameters that we are assessing under this program are the primary outcomes are implementation outcome, that's acceptability, adoption, coverage, fidelity, and cost. And then the secondary outcomes are the clinical outcomes, that is the dental caries experience, which is being assessed by DMFT, DFT, and DEMRI's index. And then we are also looking to the change in oral health behavior by behavior indicator tool and knowledge assessment practice tool. So we made a adapted consolidated framework for implementation research under this program this project, in which inner setting, outer setting, individuals, intervention, and implementation process was defined. So I'm not going to the details of the project in interest of time, but I'm just touching about the things so that you have to have an idea how these types of projects are developed. So there were various phases of the study, as you can see. In the preparatory phase, there was secondary data analysis was done, staff recruitment training was done under this phase. And then there was active mapping and liaising with stakeholders, because this project is a unique project in a way because it needs an active integration both from health and education department. So it is 2 ministry integration is required at each step of this project. So there was mapping and liaising was a very crucial part of, it is still a very crucial part of this project. So the next phase was a formative phase, which was a qualitative data collection. Under this, nearly 154 in-depth interviews and 42 focus group discussions and 308 non-formal interviews. You can see the magnus of the project that was undertaken at the 8 sites, and knowledge, attitude, and practice assessment was done, and clinical data was also collected as baseline data under this phase. The next phase was the pilot or pilot phase, where model M0 was implemented in 20 schools in each of the districts. So total 143 schools, this was implemented and tested initially. And total schools covered by nearly 20,943 schools, and total OHA activities, that's oral health education, was delivered 348 under this phase. And we had nearly 368 with brushing days. Each single day it's not a cross-sectional type of project, but each single day, the children have to brush in the school. The idea is with the midday meal, along with the midday meal program, we integrate it so that when a child eats in the school, he also brushes in the school. That was the whole idea about, making this happen. So based on the findings of the pilot phase, again, there was a co-development workshop at various levels, district, state, regional level, central level. And then the model was co-developed again, with the iterations, the changes that were required at the level to make it happen, to make more of coverage. So some iterations were done in the model, and then model M1 was implemented across all the schools, selected schools in all the districts. Now it's been almost 1.5 years that's being currently implemented, and total nearly 2,478 schools are being covered with about 3.24 lakhs children in the country, and nearly 4,686 OHG activities have already undertaken, and we have nearly 3 lakh school toothbrushing days already done under this project. So these are the various stakeholder meetings, at various levels that I have mentioned, followed by co-development workshops, and then monitoring and cross-learning site visits under this project, which are done both at site level by the site, health health system people, by the PIs, and the people already at place at the site level. And then there were also center level where we try to even take the other site co-I or co-PI for cross-learning site visits. So experts as well as the other site PI went, for a learning exercise, learning from each other. So this fishbone matrix was utilized, to move forward from model M0 to now M2. Now we are moving. So at various levels, where all the problems were written at the left side of the bone, as you can see, and the solution to that problem was written on the right side of the problem. And for each of the people, infrastructure, time constraint, logistics, reporting, monitoring, and governance policy, problems and solutions were made. For example, if there was a low parental involvement due to lack of awareness on oral health, delivering oral health education to parents through interactive session was seen through. And similarly, if there was a high student to tap ratio, a multi-hole pipe system was introduced, which was seen as a low-cost wash facility. And then if there was teacher was less in a school, so various methods were devised to cater to that problem. For example, retired teachers or Matrigut. For example, in Dibrugarh there is Matrigut thing where parents come into the school to help in the activity where teachers are less in the school. So these are the various methods that were strategies, I'll say, strategies that are put across for various problems. We try to find the solutions to make the things on ground happen. So these are just of various toothbrushing activities that are happening at various sites.
I will have to little bit interrupt here.
So I'm
Actually,
I think I'm the last
we have
2-3
to keep the
slides.
time, we have to respect the time.
Yeah,
Yeah.
I'll just. Oh yeah, I think
Yeah.
I'm on the last
It's
2-3
also going
slides.
away from the topic.
Yeah.
Little bit.
So it's a team effort. Obviously, it's a team effort, and now the Parliament Standard Committee has actually suggested, they have recommended to actually disseminate this program to whole of the country. So this is a big move that has come up for this project, and this is the impact this project can have on nearly 14 lakh schools, 95 lakh teachers, and 2.65 crore students in the country. And I just, because time is less, I understand. So we also made a community health officer workflow for oral health, which was released by Ms. Anupriya Patel and Minister of State, which is for the community health officer. We are trying to empower them as well in oral health, and various capacity building workshops, which are readily available on the website. You can keep on watching. And we have to join hands to pledge improve oral health of the country. We need to have, the mantra is local, locally rooted and globally respected. So thank you so much.
Thank you very much, ma'am. The participant would be definitely benefit from the information you provided. So before ma'am attending question and answers, we can have a brief review of the series. So Harvinder sir, should we start the PPT or the speakers are here with us?
The NAMS site. Yeah, Ravi can do it from that side.
Okay, sir.
Yeah.
So we can start the PPT, sir?
Yeah, please do start. Yeah.
Right, sir. Right, sir. Thank you, sir.
From Slide number 2, we can start. Slide number 2. Start with slide number 2. Yeah. So this is giving you some background about the titles of the topic which have been covered so far. And starting from January till now. And we had experts from different institutions, from AIIMS, from PGI Chandigarh, from Mangaluru, from Tamil Nadu, and all different places. And this one is the last one. Yeah, you can close this one. This is not required. I'm already there in the video, so you can close this PowerPoint now. So I like to mention here one thing which is very important is that the participation was huge, and in many dental schools, the deans have created a classroom type of a setting where these were being projected, and even we encouraged undergraduate and postgraduate and faculty to join. So in different institutions, they had different approach beside individual logins. I think some of the lectures were very popular on YouTube live show, and some were not that popular, but it usually goes with, but most of them were popular, some standard, some ways. On an average, we had 150 logins, I think, on the Zoom. And then in addition to that, we had YouTube logins and other logins. So now I think I like to thank each one of them who are here. Has anybody joined from previous faculty, Ravi? Dr. Jangra, do we have other previous faculty joined us today?
Sir, I'm unable to see any of the previous faculties.
I think no, sir.
Thank each one of them. And if you can run the PowerPoint from slide number 2, I will just give their names and say thank you.
Sure, sir. Sure.
Yeah, from slide number 2 better. Yeah.
Okay.
So beside me, we had Dr. Gopal Krishnan. He's a periodontist at Manipal. Then we had Sharad Ashokan from Tamil Nadu, who talked about pediatrics. Then again, I participated in the facial deformities. Then Dr. Deepika Mishra from CDR. We have Dr. Ajay Rai Chaudhary from CDR AIIMS, who talked about facial trauma. Then we have next one, please. Dr. Mitra from Mangaluru again. Slide number 4, yeah, just hold in there. Dr. Gunjan Pruthi, she talked about evangelism and also about the prosthetic surgery, particularly development with the current implants. And the one on 5th June was very interesting because this was more of a session for learning for each one of us and for each of the participants, and also useful to the families, where we discussed about how the oral hygiene devices are to be used for the kids, for the elderly, for the dentures, for the implant, and how to make their effective use. And of course, today's session, we like to thank Dr. Danny John and Dr. Nitika Monga for their time and the excellent presentation they have made, and the information provided is highly useful. I think I will move on to Dr. Jaswant for question answer session.
Sir, we have one question there with us, sir. One question which was asked, I'm unable to see that question. Ravi sir, are you able to see that question?
Yeah, sure, sir. I will just update you.
Yeah, please. Because that question is not appearing right now there.
Enjoy the video, first one. No, sir, there is no question.
So it was there in the chat box.
I think, yeah.
But if there are no questions, we can encourage participants to ask questions now.
So,
No, there is no question.
Right, sir. If anyone wants to ask questions now, because I saw one question, so they can still unmute themselves and or they can just raise their hand. We'll unmute them and then they can ask the questions.
From the participants, if you want to ask any more information, please feel free. You can unmute yourself and then even you can open your camera if you like to.
Kumar Anand.
This only shows that people are more interested, dentists are more interested in clinical work and less in research. That is another barrier which we face as a profession, you know. So if I have to make a comment which is very straightforward comment. So I think all of us, therefore, I think need an research orientation at undergraduate level. So the encouragement in research is needed. There are funding opportunities, but the issue with the dental research is, which I have been with ICMR expert for a number of years, or even with DBT and other organizations, CSIR, the good projects are missing. The ideas are good, the thoughts are good, but the effort put in to write the project is not there. So therefore, I think what probably we need to also do it to encourage research. We need to do some workshops on coming back to again to the circle, coming back to the circle route. Going around the circle is that research orientation, research sensitization, value of research, and also research workshop, how to write a good project and how to fit that project into the required grant, which Dr. Deepika said, that there are so many options available for grant. But unfortunately, we are writing a project which is not fitting into that kind of requirement of the funding agency. It may fit in somewhere else. So all these processes are very thoughtful. And more than that, I think what we need is a mentor and role model. So in dental institutions, there has to be a role model whom people look at and want to follow him as a researcher. So that is the other thing which is perhaps very much needed in our profession. And maybe Danny has some comments to make. Kumar Anand usually asks questions. Thank you, Kumar, for being in every meeting, you know. And some of the participants are there for all the lectures. So Kumar is one of them. So I'm sure he would have something to ask. Please, go ahead. We can't hear you. You are muted.
Unmute yourself, Dr. Kumar.
Sure. Very good afternoon to all the respected faculty and senior faculty members and teachers, sir. Sir, one question from a very long time and many places I have seen that regarding the journals, sir. Sir, how to know that whether a journal is a predatory journal or a genuine journal? Is there any site or something list of journals indexing has been provided so that we can know if we before publishing that we should go for publication or not in this particular journal, sir?
I think Dr. Danny John mentioned a lot about it. I will request him that if he can explain again.
Yeah, so till 2015, this, am I audible? Yeah.
Yes, sir. Yes, sir.
2015, it was little straightforward because Jeffrey BL, who was a librarian, used to maintain what is called as BL's list of predatory journals. What happened in 2015 was all the journals that he blacklisted protested against him, and he had a threat to his life. And he had to stop that list, and his friends, in fact, moved the list from that day onwards to every other URL so that his identity and location is not identified. So that is the level at which the danger of predatory journals has reached. Subsequently, what has happened is that there is no single way to identify whether a journal is predatory. There is this think, act, do checklist. And this is something when I teach PhD and MDES students on how to identify, it's as difficult to identify whether a person's intention is right or wrong. क्या वो सही में मेरे से is he with me or without me? It is that difficult to identify whether a journal is predatory. Mainly because nowadays journals actually tend to see or similar. The predatory journal interface also looks similar to the original journal. But I'll just give some quick tips since you've asked the question. The first thing you look at is who's the publisher, right? Don't bother about the Scopus PubMed. PubMed index for some reason is journals are little safer. So if the journal is indexed in Web of Science or in PubMed, it is a little bit safer. If it's only on Scopus, it is still problematic because even in our list, when we did the research, 17% of our papers, when we did the review among some 5 systematic reviews of studies, we found that even scope and index journals have predatory. So the first thing you do is whether they are index, check whether they're PubMed or Web of Science or Scopus. If they're PubMed or Web of Science, it's better, little bit better. But if it's only Scopus, then you need to take the next step. The next step is to identify who's the publisher. Now, if the publishing office in India, then you have to check whether the office is in Hyderabad, because Hyderabad is the place where all the predatory journal offices are located. Either Hyderabad, Telangana, or Chennai. These are the 2 places where it is there.
Ahmedabad and Noida.
Ahmedabad and Noida is also coming up. Okay, fine. So there are 2 more cities that are picked up. So that is where you identify. Then you check who are all on the editorial board. Who's on the editorial board? If you find a lot of China, lot of Indian members only as members, or countries like Uzbekistan or Kazakhstan, then you have to worry about that journal. That's the next step. And finally, check the publication fee. Check the publication fee. But the most important thing is check the average period of when the submitted date to the accepted date is. Just look at the articles, check if the submission date to the accepted date is less than 2 months in most of the articles, I can tell you very clearly that the entire peer review is compromised. There is no way humanly possible, even with AI, you can do a good review by 2 members blinded with at least 1 revision coming. All journals will not, you can't develop 1 revision, acceptance, everything in 2 months. So these are some few tricks that I can tell you. Otherwise, there is no single website or a list to check whether a particular journal is predatory or not.
Yes, sir. So, just one more thing, sir. Let's suppose if I'm getting a publication in less amount of cost, why should I go for a publication house which in which I have to pay more? And all the factors what you have said, some way or the other, they are not present. और मतलब सर इतना तो कोई अगर अंदर जाके तो peer review journal उसमें कितने मेंबर हैं, वो किस कंट्री से एफिलिएटेड हैं, सर ये कैसे मतलब इतना किस किस जर्नल पे आदमी मतलब किस किस जर्नल पे इतना कोई समय दे पाएगा सर, जो मतलब एक बहुत फ्रैंक सी बात है सर.
Kumar, I will reply. It is like this, that most of the people who are in this business, like those who have spent 15, 20 years in publications, your teachers, they mostly know which journals are good, which journals are bad. You know. So if you
Yes.
take their advice, like we know, we go for interviews all over the country. We
Yes,
face
sir, yes.
friends coming with faculty, researchers coming with articles. The first thing we tell them that please keep these articles away. Tell me, is there an article which you have published with this impact factor, this index, or this? Then Raddi alag ho jata hai. The truth becomes that. So it is there. It is the problem because their teachers, their mentors have not guided them that please don't go this way. Rather, sometimes I'm sorry to comment here, they have encouraged them because they are getting the ghost authorship or the guest authorship name there. See, this is
एक
what-
बात ये कहना सर, एक बात ये कहना चाहूँगा कि एवरीबॉडी सर हर समय तो आप मिल नहीं सकते हैं ना सर. आपके ये सब
हमने
मेंटरशिप मिलना सर, सर आप अगर गाइड होते तो that would have been another thing, but as far as मतलब my concern is कि अगर गाइड एक ठीक नहीं रहते हैं तो मतलब अपने पे अगर सर न्यू कमर्स के लिए सर हम लोग तो उतना भी नहीं जानते, वी डोंट नो एज ऑफ नाउ विच जर्नल इज द बेस्ट लिविंग सम इंटरनेशनल सर, दैट इज व्हाट आई वांट टू से सर.
Anyway, you will grow and know, learn. Sometimes mistakes are the best lessons in life, you know. So, but the best thing is if you don't get to do mistake, if you could do without mistake. But if it happens sometimes, that is also a lesson. I would say that way.
सर एक क्वेश्चन और पूछना था सर.
जरूर पूछिए.
सर एक निकिता मैम से पूछना था सर.
पूछिए ना, वो तो बैठी हैं, वेट कर रही हैं आपका.
मैम
Please tell me, Dr. Kumar.
good afternoon ma'am.
Good
Ma'am,
afternoon.
in one of your slides or two of your slides, I just saw that the MBBS or the MD were having 80% of those, and the BDS or the MDS 20%. Is there why? First of all, I would like to ask why, and secondly, ma'am, if it is if a BDS or MDS is having a good topic to a good topic of research rather than considering those, will it be considered or not?
Yeah, so there are two separate questions. So I'd like to address first. First, we are in a medical research body, and these guidelines, they go through a parliament approval process, and there's a proper document which the parliament approves. So it's not something which, it's in my hand that I can do it, but yeah, I can definitely convey this forward. But still, you have to be probably happy in a way that at least 20% for dental people is there. We have to probably see how much is full and how much is empty. At least 20% we have in place specifically for dental people. It is not for veterinary or it is not for nursing. There are many other allied sciences and many other areas of people, but they have all been put together into one category, and we have exclusive 20%. So this is other way of looking about it, which I think it's a good thing that we have an exclusive quota for that to actually bring up research in our area, because now oral health is an overarching area at ICMR, so that's why probably we have an exclusive thing for us in place.
Okay, ma'am.
There was a second question, I think. There was one more question. Can you repeat the second one you said?
Ma'am, I asked that if a topic in 20% is if a person who is securing a seat like 21st% and his topic is good rather than comparing of the 88th%, whose topic should be selected? I think it is a ma'am. What I want to convey is that rather than giving a percentage, we should look for topic wise more, ma'am. मैं ये कहना चाह रहा था. And rest it is
It is
okay.
generally that way, but it is not fixed that 80-20 ही होगा. It's not that way.
Okay,
if it is
okay.
better, we do consider. It's not like that. It's very stringent and fixed. It is a general percentage that's given.
Okay, ma'am.
So
Thank
that,
you.
situation should not be, because somewhere we have to, because I've been working here for last 7 or 8 years. I've been seeing projects both in oral health and gastroenterology. So I just wanted to put forward this word that probably in research quality, we really lack as compared to medical fraternity somewhere. For example, what challenge I face is when I see experts, when I have to pick up experts from oral health. For gastroenterology, though, I can easily get for 100 H index or 70 H index. But for oral health, for picking up experts for oral health, I hardly get above 20 or 25 any expert. So that is a challenge, and this actually gives an indication where our oral health research quality actually stands in the country. Though we have the highest number of dentists globally in the country, but in terms of research, we are probably really lacking as compared to medical fraternity. So, in a way, when we say 20% for at least for oral health, we are at least fixing some quota for oral health, so that it is not left behind. It is probably applying an equity principle. We must be aware of
Okay,
an
ma'am.
equity principle in oral health.
Mhm.
Probably you're applying that for oral.
ठीक है मैम,
Otherwise,
thank you.
there's high chance when medical people review our projects, they get rejected because our
Okay.
quality is probably not at par with them still.
Okay, thank you, ma'am. Looking forward to work with you, ma'am, in future.
Yeah.
I hope so.
I hope the quality we come to that level.
Yes,
you know.
yes, definitely, ma'am. Definitely, ma'am.
Thank you.
Thank you, ma'am.
We will add little background on 80/20. I wish to tell you how it was done earlier. It may not be stand test of the time today because it was created based on the number of seats available, postgraduate
Okay.
seats. When it was coming for, because thousands of applications were coming, it was not possible to try merit list for all the medical and all the dental combined. So at that stage, it was thought that if the number of seats for postgraduates are 100, and if 80% of the seats are on medical side, all health disciplines, so 20% was given to dental that time. But I do not know what is the ratio of seats now because it's a dynamic. So, but I think you should be happy with what we have. Yeah.
Yeah. ठीक है, sir. Okay, thank you, sir.
So is it time to now? Any last words coming from Dr. Daswant, and is Dr. Gupta joining us?
Sir, I'm unable to see Dr. Gupta sir here.
He mentioned he will join in the.
Yes, sir. Yes, sir. His name is also there in the program list.
Okay. So if not, then maybe we need to come
So
to.
Dr. Gupta is not here.
Okay,
Achha.
thanks, sir.
Not joined.
So we can come to the concluding remarks. Yeah.
So, sir,
I think-
over to you for the concluding remarks, sir. Since you have been the pillar of this series, and this has been a wonderful and unique series, I would say. So, what do you,
Starting
sir?
and ending from you, sir.
Sir.
First of all, I would say I'm so thankful to the National Academy that they accepted my proposal on oral health. You know, within that big aura of medical and super medical experts, oral health got its opportunity of time. And that time was not just for 1 or 2 lectures. We had a full series of 6 months going on. And then the next challenge was the topic. And the next challenge was who should be the speaker. And so one has to be very, very careful on that. In fact, except for this lecture, most of the speakers shared their PowerPoint before and they were reviewed. But I was so confident about Danny and Nikita, we did not request for it. And we were sure they will do the great work, and they have done the great job. So I would say that the time has come that when people in general, also in the medical field, we needed to sensitize those people about the different aspects of dentistry which were missing. These lectures were not just for dental people, they were also for the medical postgraduates and for medical faculty. Now, we need to see the feedback. If there are any feedbacks have come, formally or informally have been recorded by NAMS, that would be great. And we'd like to thank the entire National Academy for this opportunity, and thank each of the contributor who have done selflessly this job. It is not easy to prepare, condense the whole subject in 1 hour. For example, the whole conservative dentistry was compacted in 1 hour. The whole oral maxillofacial trauma was compacted in 1 hour. So people have done a great job, and I think a letter of appreciation should go to each of these people. And I'd like to thank each one of them. And I would think it has also brought many of us together. And we had a chance to have a thought process exchange across. With this, I think we'd like to thank, and to this one, he has done a beautiful job. Perfect coordination, minute-to-minute coordination. Ravi, excellent. The technical team at the
Thanks,
National
sir.
Academy has done a great work. I'm sitting here, but Ravi will is in touch with me every few minutes. Yes, like ye karo. So he even replied me early morning, 6 o'clock today. I think something I remembered, I texted him message early morning, reply came, here it is. So Ravi, thank you so much, and to all your team. If he is
Thanks, sir.
listening.
Welcome, sir. Thanks.
Look at it against their names.
We call, so anything from you, this one, you want to say, please go ahead.
Thank you, sir. Thank you for the kind words, and for the participants, a big thanks to all of you for attending this. And like without the participants, like we can't proceed, or we can't, we are nothing. So for the information, all these lectures are available on the website. If anyone has missed or they want to revisit any of the portion or maybe the entire presentation, they can just visit the website and can look up at the lectures. And also the videos are available on the YouTube. So whichever is convenient to them, they can visit. And again, special thanks to Professor Kharbanda sir and the speakers of the day, Professor Danny Jones sir and Nitika Monga ma'am. So I think, sir, with your permission, can we mark the closure of the session?
Yes, we can. And thank you, everybody. So much.
Thank you, sir.
Thank you so much.
Okay, sir. Thanks, sir. Okay.